Methodist DeBakey Heart and Vascular Center Grand Rounds. I'm pleased to have with us today Dr. Andrew Wechsler from Drexel University. And before I introduce Dr. Wechsler, just a couple of housekeeping announcements. We obviously want this to be interactive Grand Rounds. And so if you have questions, you can either text them or text DeBakey to 37607. Or you can go to pollev.com/DeBakey to enter your questions, and we'll have some time for questions at the end of Dr. Wechsler's talk. And also, we've got a panel with us here, Dr. Mike Reardon, who is obviously a renowned cardiovascular surgeon here at Houston Methodist, and Dr. Sachin Goyal, who's our structural interventionalist, will be here to ask questions as well with Dr. Wechsler. So let me introduce Dr. Wechsler. He's the Emeritus Professor of Cardiothoracic Surgery at Drexel University. He's the Editor Emeritus of the Journal of Thoracic and Cardiovascular Surgery and past Editor-in-Chief of the American Association for Thoracic Surgery. And he's the previous chair of the Department of Cardiothoracic Surgery at Drexel University. He has really a long-standing research career as well. He was chairman of the NIH study section for surgery and bioengineering and has held really numerous NIH grants in the field that he's really spent his lifetime working on, which is myocardial ischemia, reperfusion injury, and ventricular performance and valve surgery. And he's very accomplished academician as well, with over 330 peer-reviewed publications and 59 book chapters. Dr. Wechsler today is going to speak with us about left ventricular restoration for treatment of post-infarction cardiomyopathy. So Dr. Wechsler, we're very pleased to have you with us virtually, and I'm going to turn the floor over to you.
Well, thank you very much for that introduction. It's really a pleasure to be here, even if only virtually. Houston Methodist Hospital is certainly world-renowned for its cardiovascular programs, and it's a great honor to be speaking there. I'm going to speak today about a minimally invasive approach for surgical ventricular restoration, a procedure that you may have more or less familiarity with, depending on how long you've been in the field. Okay, I'm having the trouble of, I can't advance the slide again. So our audiovisual guy here.
Tyree?
I think I stopped sharing and then try and get back onto the share screen, and that sometimes works. Perfect. So I have a couple of relevant disclosures. I do consulting work for BioVentrix Incorporated, and it's a company that makes a product that we're going to discuss later in the talk. However, none of these uses that I'll describe are off-label. After an acute myocardial infarction, the myocardium affected dilates, thins, and becomes scarred. And over time, as the contractile units from that region are lost to the ventricle, the remainder of the ventricle also dilates. As that process of dilation occurs, the papillary muscles also are placed under increased tension, and the consequence is the development of functional mitral regurgitation, most often involving the posterior papillary muscle, affecting the posterior leaflet of the mitral valve. Although there are many changes on the cellular level, most of which are moderated by neurohumoral influences, it's important to recognize that there are important structural changes in the myocardium. Specifically, cardiomyocytes lengthen, the ventricular wall thins, The infarct expands, not to be confused with extension, which is the addition of further necrosis to the infarct. There's absorption of inflammation and necrotic tissue, and myocytes hypertrophy as they try and compensate for the lost contractile units associated with the infarction. Ultimately, collagen accumulates in the interstitium in the region of the infarction with the formation of scar. And over the passage of time in the dilated ventricle with increased wall stress, there's continued expansion of the infarcted area and dilation of the ventricle. Having that slide advancement issue again, let me just see if I can fix it. Okay, so in this cartoon, you can see that after the initial infarct, the long-term prognosis and potential for recovery depends very much on the extent of dilatation of the ventricle. Ventricular volume is extraordinarily important, and this is referred to as global remodeling, which takes place over days to months to years. The three things most associated with this ventricular dilation are an increase in wall stress, an increase in left ventricular end systolic and diastolic volume, and an accompanying decrease in the ejection fraction. If one is looking at the long-term outcome of patients who have ventricular dilation, there have been a number of studies that have pointed out the importance of ventricular size. In this plot by Magrino, you can see that the risk of both heart failure in blue and mortality in yellow is plotted against the range of end systolic volume. It's very clear that as end systolic volume increases, there is a marked increase in the risk of either heart failure or death. In a very large meta-analysis of a large number of randomized clinical trials, a plot was made of the odds ratio for death in large RCTs versus the difference in change from baseline end systolic volume associated with treatment of patients with heart failure. There evolved a very strong relationship, highly statistically significant, between the probability of death or rehospitalization depending on the end systolic volume. And whenever the end systolic volume tended to increase, the consequence was a great risk of increased mortality, or expressed inversely, a decrease in survival rate. It seemed like the obvious solution to this was the advent of early percutaneous coronary intervention and opening up of the infarct-related vessel. Unfortunately, as the opportunity to study this further evolved, it was clear that even early PCI in very, very high quality units did not consistently prevent remodeling. And here are just three studies, one by Bolognese, and their conclusions, which were significant left ventricular dilation occurred in a relevant proportion, 30% of patients with acute myocardial infarction that was successfully treated with primary angioplasty. In another study by Savoy, recent improvements in acute myocardial infarction management do not abolish left ventricular remodeling, which remains a relatively frequent event after an initial anterior wall infarction. And finally, the recognition that that not all patients receive prompt treatment, and as many as 20% of patients may arrive greater than 12 hours after the onset of the ischemic event. Greg Stone looked at all-cause mortality plotted over the time in month in an attempt to equate the size of the myocardial infarction with the probability of death. In the highest quartile, shown in red, in which there was 29 or 30% of myocardium infarcted, you can see that this was associated with 4 times the rate of mortality from those who had a minor myocardial infarction. When mortality was combined with hospitalization for heart failure, that was 8 times the probability of patients receiving the same adverse consequence who had a minimal myocardial infarction. So the relationship between infarct size, remodeling as manifest by end-systolic volume index, and outcome are clearly established. In this simplified slide, cartoon, is illustrated a patient with congestive heart failure and the ideal of treatment strategy. Patients who have congestive heart failure and dilated ventricles are far along the end diastolic pressure volume curve, with high end diastolic pressures, decreased stroke volume, and markedly stunted end systolic pressure volume relationships, which relate to myocardial contractility. The goal of treatment, that is guideline-directed medical therapy, devices, correction of any physical abnormalities in the ventricle, ought to bring the patient towards the left, back into a more normal part of the end diastolic and end systolic pressure volume curve. Being far out on the right of the end diastolic pressure volume curve and end systolic pressure volume curve associates the patient to increased demands for myocardial oxygen consumption, since this is definitely related to the area under the curve shown in green. From this realization, and knowing that the goal of medical therapy is to bring the patient leftward on this curve and create reverse remodeling, it was intuitive to try and accomplish the same thing using a surgical technique. And this resulted in the evolution by Vincent Dorr in Monaco of surgical ventricular remodeling. Conceptually, this is a simple procedure and accomplishes several things. Wall stress is related to Laplace's law and is determined by the intraventricular or intracavitary pressure times the radius divided by 2 times the wall thickness. So here, in a dilated cardiomyopathic ventricle as a consequence of a large anteroseptal myocardial infarction, you can see the dilated diameter of the ventricle. The Dorr procedure involves restoring a much smaller circumference to the heart and greatly reduces the left ventricular internal diameter. The procedure is conceptually simple. One cuts through the scar and either pulls the walls of the ventricle that are normal together with sutures, or when that results in too small a ventricle, a patch is interposed between the normal portions of the cardiac wall, thus greatly reducing the size of the ventricle and reducing the myocardial oxygen consumption and improving cardiac performance by minimizing left ventricular wall stress. However, the ventricular restoration procedure is a high-risk procedure. There are risks associated with cardiopulmonary bypass, risks associated with the mandated ventriculotomy. It has been shown to have a high morbidity and mortality in inexperienced hands. And of course, many cardiologists tend not to refer patients for invasive procedures unless they're the ones doing them. In any event, this is an example of a patient in the midst of a TOR procedure. This was a patient of mine. And to help orient you, this is the apex and lateral wall of the left ventricle. What you're looking at here is the scarred ventricular septum. And here's more septum that's scarred. And as you work your way around the ventricle and go further posteriorly where my arrow is, you can see the normal myocardium. The procedure would involve excluding the scarred myocardium from the left ventricular chamber and bringing normal contractile walls into apposition with one another. There was considerable skepticism about the efficacy of this procedure, even though it was being widely performed. Oops, sorry, just trying to advance my slide again. Same problem, so let me just fix it. This was subject to study in a large NIH-funded study called the STITCH study. It was directed by Bob Jones from Duke University. And the idea was to compare a randomized selection of patients, some of whom underwent coronary revascularization, and others of whom underwent coronary revascularization in association with surgical ventricular reconstruction. The results were rather surprising and also very clear, and that is that at the end of the study period, 5 years, the probability of death or cardiac hospitalization was no different between the two groups. And when isolated alone as the secondary endpoint, there once again was no difference in survival rate between the two groups. Thus, it appeared that the addition of ventricular remodeling to coronary bypass grafting had no beneficial effect. However, there were many flaws with this study, too many to go into in the time allotted today. But many believe that this study was more a study of ischemia and the effect of revascularization than a true study of the effect of surgical ventricular remodeling. Here are the results from the study that are worth looking at a little more closely. These are the starting end systolic volume indices for the patients who received both revascularization and ventricular reconstruction alone. And as you can see, their post-operative change in size was about 5 milliliters per meter squared as a consequence of bypass surgery alone. In the group that underwent surgical ventricular reconstruction, there was a larger change in the end systolic volume index. However, even that larger change was relatively small compared with other studies that had been published within the literature. In fact, when you compare the results in the STITCH trial with the published observational studies involving hundreds of patients, you can see that the extent of reduction in end systolic volume index of the STITCH patients, shown in red, compared with many of the other studies, was much less. And if you subtracted that change, which could be attributed to revascularization alone, it was really only about 13 milliliters per meter squared. As a consequence, there was a strong feeling that the ventricular reconstruction, for a variety of reasons, performed in the Stitch study was in fact not very effective in reducing ventricular size. And drawing a conclusion as to the impact of ventricular size reduction on mortality was therefore importantly flawed. In a post hoc analysis, in fact, in a couple of them, Rob Mitchler looked at the Stitch patients and divided them into two groups arbitrarily. In one group, the reduction resulted in a left ventricle that was less than 60 milliliters per meter squared. And the second group were those patients who had a reduction greater than 60 milliliters per meter squared. The consequence, when looking at all-cause death, was that those patients who had greater reduction in their end-systolic volume index had a greatly improved probability for survival. Another way of looking at the same problem was to look at the percent reduction in left ventricular end-systolic volume. And those patients that had a 30% or greater reduction in end-systolic volume had a greatly reduced probability of death compared with those patients who had a rather inadequate reduction in end-systolic volume index. Now, the door operation conceptually is a really simple operation. The idea is to cut into the scarred anterior septal scar and then simply using sutures to bring normal myocardium into close apposition with other normal myocardium. And in those rare instances where doing this did not or resulted in a ventricle that could be too small, a small patch would be interposed to keep the ventricle at an adequate size. So the question evolved, what if there was a less invasive way to do ventricular reconstruction that did not involve sternotomy, cardiopulmonary bypass, cardiac arrest, and even ventriculotomy? What I'm going to discuss for the remainder of this talk is the technique that has evolved and the clinical trial that Houston Methodist Hospital is going to be participating in. Here once again is the cartoon of a left ventricular scar. And here once again is the result of a door procedure or ventricular reconstructive procedure in pulling this wall together and excluding the non-contractile component from the left ventricular cavity, except in this model, there's no incision made into the ventricle. And these scarred portions of the ventricle are brought into apposition by the placement of an internal compression plate within the right side of the interventricular septum that is mated with an external compression plate on the external surface of the left ventricle within the scar. The question is, how is that done? The compression plates are 2.5 centimeters in length, and when assembled, they are connected by a PEEK, just a chemical or plastic, and these compression plates can be pushed towards one another. The idea is to place a compression plate on the right side of the interventricular septum along the scar, by a rail to the outside on which an external compression plate can be put to bring them. The procedure requires the collaboration of an interventional cardiologist and a cardiologist. The interventional cardiologist works at the patient's neck and uses a catheter inserted into the right ventricle by way of the internal jugular, through which a variety of catheters and instruments, including the compression plate, can be passed. The surgeon works through a mini thoracotomy where he can visualize the external surface of the left ventricle and place a needle through the left ventricle, across the septum, and into the right ventricle, where it can be grasped by the interventional cardiologist. The final step, once a rail is created, the internal anchor and the external anchor are connected. And that's shown better in this movie. So we can see here, this is a typical patient who would receive the procedure. This is a 2-chamber view of the left ventricle. And here is a 4-chamber view of the left ventricle. You can see the large non-contractile area at the apical septal region. And the goal of the procedure would be to exclude this component of the ventricle from the left ventricular cavity. The procedure works better than the slides. As shown above. In the first step of the procedure, the surgeon places a needle across the LV wall, across the septum into the right ventricle, and the cardiologist snares that needle through which a wire is passed, and then a larger, actually a dilator catheter. This establishes a rail for continuity between the cardiologist and the outside of the patient at the level of the patient's neck, and the left ventricle accessible to the surgeon. In the final step of the procedure, the cardiologist brings the anchor down against the ventricular septum. The surgeon places an external anchor, and the two are compressed, thereby excluding all of this from the left ventricular cavity. This can be seen a little bit clearer on the next slide. Here you see the internal anchor being deposited by the cardiologist and connected by a rail to the surgeon, who compresses it. And this is done along the entire length of the scar on the anterior surface of the left ventricle, thereby excluding completely the scarred area from the contractile component of the left ventricle. And there's the row of internal anchors on the septum and the external anchors on the left ventricle. You can This is a view taken during such a procedure using transesophageal echocardiography. And what you will be seeing is, in the initial view, is the compression plate on the septum and that on the anterior ventricular wall, the two connected, and then the effect of bringing the two together. So here is the compression plate on the right side of the septum. There's a compression plate on the external left ventricle. This is the connecting tether.